about transitions between pharmacotherapies for opioid use disorder, specifically rotation from formulations of OAT to slow-release oral morphine. Before we proceed into our case discussion. So by the end of this session, you should be able to, we're going to review the characteristics of slow-release oral morphine as a form of OAT to help inform whether it might be an appropriate choice for an individual. We'll talk about the safe and effective transition of a patient from methadone to slow-release oral morphine. And similarly, we'll talk about the transition of a patient from buprenorphine to slow-release oral morphine, and just sort of some general considerations throughout about rotations between any form of OAT and when that may or may not be appropriate. So not really intending on getting into great detail on different formulations of OAT or slow-release oral morphine specifically, but just to recap, buprenorphine, naloxone are one of our more commonly used formulations of OAT in the province, a partial mu-opioid receptor agonist, a great safety profile, a very effective form of OAT, particularly for people with significant comorbidities due to its ceiling effect for respiratory depression and milder side effect profile. Contrast that with methadone, which is our sort of most long-standing form of OAT, full mu opioid receptor agonist, and a very effective form of OAT, but one that does come with a high risk of overdose, more significant side effect profile, and that certainly is more controlled in the way that we administer it in the province. The third option, slow-release oral morphine, is the newer kid on the block. It's certainly been around. We've got 2017 started prescribing it in BC, so 6 years of clinical experience with this medication now. I think it's becoming more and more commonly used and much more comfort with this as an agent, but still certainly not near as much data supporting its how to use it safely compared to buprenorphine or methadone. Another full agonist, another agent that does come with a risk of overdose and thus is more controlled in the way that we prescribe it and administer it in the province. Take-home doses for slow-release oral morphine are not traditionally recommended in our current guidelines, although in particularly long-term stable patients, there are caveats to that. To also preface all of this discussion around these agents and the outline that I'm going to provide on slow-release oral morphine with the fact that this is all taken from our 2017 guideline, as well as a update that was put out by the BCCSU in early 2022. We will expect a full revision to the opioid use disorder guidelines in spring to summer of 2023, which will mean some changes in some of the things that I'm describing. So everything that I'm talking about here is from our existing guidelines, but that's sort of a preview that we will see some small changes in our next version later this spring, hopefully. So when seeing a patient, when you're considering a possible transition between OAT medications, I think that there's a number of considerations. So first off is one indication or reason why you may consider changing formulations of OAT is if your current formulation is if you feel the dosing has been optimized, but you're seeing no change in their non-prescribed opioid use, an increase or reinitiation of non-prescribed use, or continued use, increased use, or reinitiated use of other substances. In other words, if we're not seeing an individual meet the goals that they're setting for themselves. A second, other very reasonable indication why you may consider rotating between forms of OAT is patient preference. For some specific reason, they're no longer interested in the formulation of OAT that they're currently on, and they want to talk to you about alternatives. Or third, maybe other reasons related to health, wellness, or quality of life. So that may, again, comorbidities, that may be individual characteristics of the medications that make you want to raise this conversation with a patient and engage in this conversation collaboratively, based on your clinical judgment, their preferences, and one or even more than one discussion on what may be the most optimal medication for them. Specific indications why you may consider rotation to slow-release oral morphine specifically may again be that they've trialed other or multiple other forms of oral OAT without reaching the goals that they set for themselves. If they are having intolerable side effects from another form of OAT, if they're on 80 milligrams of methadone, they're still finding it subtherapeutic, but they're experiencing significant hyperhidrosis. It may not be the right agent for them. Or if other forms of OAT are contraindicated, for instance, if somebody has congenital long QT syndrome and methadone may not be the right option for them. Lastly, and probably most importantly, is if a patient expresses a particular preference for slow-release or morphine, for some reason based on their goals, or their past experiences, this is just the agent that they want to try today. I think that's a very reasonable reason in and of itself to help facilitate this rotation. Once you have a discussion with them about kind of all of the considerations involved before making such a change. Just a note to be very clear, patients do not necessarily have to trial buprenorphine, naloxone, or methadone before beginning with the slow release or morphine. It is very reasonable to start there if it is the agent that a patient is interested in and that is most consistent with their goals and preferences. These are the contraindications for slow release or morphine. They're taken from the product monograph. Really, the only absolute contraindication to any of these agents, in my experience, is an allergy to component of the drug. Everything else is based on clinical context. So severe respiratory insufficiency listed here, certainly not an optimal time to be initiating one of these medications. And certainly if they have significant respiratory comorbidities, a full agonist may or may not be the appropriate agent, but none of these are absolute reasons to avoid it. They're considerations, I think, to having a discussion with an individual. And I won't go through the rest of this list. This is all available online on our post-P modules. Again, to reiterate, slow release or morphine, fairly specific pharmacology. It's quite a bit different from other forms of OAT that we use. Just to remind everyone, it's a 24-hour formulation of morphine. It is morphine, that's the active agent. It's the proprietary technology and the slow release formulation that leads to its delayed, or that it's a prolonged effect. Peak plasma levels for slow release or morphine or for Cadian are very delayed, between 8 to 10 hours. And this is a common misconception. I think that's much different from methadone, which is 3 to 4 hours, or buprenorphine, which is less than an hour. So peak plasma levels very delayed. Elimination half-life is 11 to 13 hours. It's really the peak plasma levels plus the half-life of morphine itself, and the plasma elimination for half-life is 2 to 4 hours. An asterisk here that twice daily or 12-hour extended release formulations like SROM have never been studied for the treatment of OUD and are not recommended except for in situations where drug shortages occur, which has happened in Canada in the past. Missed doses for slow release or morphine, obviously potential for rapid loss of tolerance after missed doses. So determining dose adjustments that may need to be taken into account after multiple missed doses requires a fair amount of clinical judgment, considering their total daily dose, the number of missed doses, whether or not they've been using other opioids during that period. This is our current guidelines recommendation around missed doses. So with a single missed dose, there's no dose change required. With 2 missed doses, we decrease it by 40%. So we give them 60% of the dose. 3 missed doses decreased by 60%, etc. This is all in the appendix for guidelines, and something that I would refer back to often, and I do refer back to often, although again, I'll point out that there will be some changes to this made in our upcoming guidelines. Maybe more importantly than the details, which I think many people here are familiar with and are all really clearly laid out in the appendix for a guideline, is just the overall evidence for slow release or morphine, because this is a topic that comes up in conversation quite often. How does this stack up against buprenorphine and methadone in terms of its performance? Yeah, I hear it said that there is really little to no evidence for slow release or morphine, and I push back against that. There's at least 4 randomized clinical trials and quite a wealth of clinical experience in Europe. There are at least 3 meta-analyses that have been published on this subject. So there is data to help guide us in the use of SROM, but it's certainly far less evidence-based than methadone, which we've been using for 60 years, or buprenorphine, which we've been using for well over 2 decades. So just to kind of summarize in 3 bullet points the evidence for slow release oral morphine. Based on what we know about existing trials, no significant difference in treatment retention compared to buprenorphine, naloxone, or methadone in medication adherence or in illicit opioid use. So In other words, non-inferior to methadone is the agent that's most commonly compared to in the trials that do exist. Probably little to no difference in adverse effects, although there's one particular study that says in some people there may be slightly less subjective adverse effects on SROM compared to methadone, and that transitioning from methadone to slow-release oral morphine is quite well tolerated in patients who are responding poorly to methadone, leading to reduced withdrawal symptoms and cravings, improved physical and psychological health observed over time. So quite analogous to methadone, certainly differences in its characteristics and situations where it may be better or worse. So moving on from that, which is just a quick review of slow-release oral morphine in general, talking about the subject matter today is out transitions. And I think there's a few considerations that need to be discussed anytime an out transition is being considered, whether that's to methadone to slow-release oral morphine or the other way around. These are periods of transition which require a fair amount of thought and discussion and collaborative decision making with an individual. So anytime an out transition or an out start for that matter is being discussed, I think it's really important to go back to square one and review all of your OAT options, all the individual risks and benefits, and discuss any possible rationales that are out there for the change. Sometimes those rationales are sort of part and parcel with the medications themselves, and sometimes there are things that we can actually do something about and may not necessarily necessitate a change. So every time I consider a rotation or a restart, I go back to square one and talk about all the options, just because, as I often say to patients, is that people's individual needs from their medications vary at different times in their life and at different points in their relationship with substances, and so it's always worth going back to review all the options and see what best fits their goals in this particular moment or encounter. When you are planning an actual transition, it's important to consider the implications of what happens if that transition doesn't go well. If the new form of OAT that you're moving to does not end up meeting their needs or expectations. By this, I'm really getting at somebody who's, let's say you have somebody who's on 200 milligrams of methadone and they're doing reasonably well. They're stable, they're abstinent, but perhaps they feel tired, perhaps they're having some sweating, or perhaps they're just tired of methadone and they want to explore other options. That's an entirely reasonable situation to be talking about a possible rotation for to Cadia, or to Sublocade again for that matter. But it's very, very important to talk about what the switch will look like, both in terms of the switch itself as well as what the weeks after may end up looking like. Because it's going to be very different rotating somebody from 200 of methadone compared to 60 of methadone. And by that, I mean, if you rotate somebody from 200 milligrams of methadone to Cadian, and they stay on Cadian for 2 or 3 weeks, and they decide for whatever reason they don't care for it, you have made a lot of work for you and for them to switch back to methadone if that's where they want to go back to. Similarly, not the subject of what we're talking about here today, but same if you're switching somebody from methadone to buprenorphine. I'm happy to do that from any dose of methadone to switch them to buprenorphine, but we need to recognize and talk about the fact that if they don't end up caring for buprenorphine and you need to restart methadone 3 weeks later, you've made a tremendous amount of work and put them at potential risk of destabilization. So I think it's really important to kind of consider all of these implications before making the switch, particularly if somebody is, stable or somewhat stable. I think it's also important to counsel people on the fact that anytime we're doing these transitions, we stay in contact quite frequently. There's lots of communication. I think we're fairly good at it, but anytime we're making a change, in somebody who's stable, mild withdrawal symptoms may occur. And transitions are often relatively smooth, but there's often need for some adjustment along the way. So it's important that they're in a position where they're aware of that and ready to tolerate it, and you have a plan in place should they have some withdrawal symptoms or some cravings that resume until you get them on the new form of OAT. So I think these are general principles anytime we're talking about any rotation at all. More specifically, we'll talk about now the rotations of methadone and buprenorphine to slow-release oral morphine, starting with methadone. So transitioning from methadone to slow-release oral morphine is deceptively tricky. It's not a particularly easy change to make, which is why it's the subject of this session today. The good news is that no washout of any previous treatment is needed. There's no concerns about things like precipitated withdrawal, like there is when you're switching people to buprenorphine. We can make that transition either quickly or slowly without any need for a washout. When we're trying to calculate morphine milligram equivalents, we usually recommend a ratio of between 1 to 6 or 1 to 8 methadone to SROM. So, and that's used to help determine approximately what we think that their stable dose of SROM may be once the rotation is complete. We may use a more conservative ratio of 1 to 4 when clinically indicated. So, for instance, if somebody was on 100 of methadone, you might estimate that they end up at 600 to 800 of slow-release oral morphine, and use an even more conservative ratio if there was particular worry about toxicity. Now, one of the common questions I have when asked about these rotations is why are we so cagey in that recommendation? You know, if we can talk about morphine to hydromorphone and say, you know, 4.5 to 1 or whatever, like why are we so evasive in providing a specific number when we're rotating to methadone or from methadone? And the reason is that methadone unfortunately doesn't really lend itself to having that consistent ratio. So I'm not putting this table up here for any reason. I don't want you to actually focus on the numbers here. This is just an example of a number of different authors who've proposed schemes to rotate to calculate morphine equivalents from methadone, and you can see, one, there's a relatively significant range in the ratios that they proposed, and two, the ratios that they proposed are not linear. They're dose dependent. So rotating off of a lower dose of methadone may use a different ratio than rotating off of a higher dose of methadone. So that's just to say that we're not being we're not providing this range just to be difficult when we're talking about these guidelines, is that we're trying to provide a range window that is practical and easy enough to remember and implement, but respects the unique pharmacology of methadone and the fact that there isn't really a consistent number that we can identify, and that's where the clinical experience comes in, and that's where if you're newer to this game and would like to speak with the race line or the 24/7 line, that's exactly the kind of question that we're here for. So, two possible methods when switching somebody from methadone to slow release oral morphine. There's sort of a gradual transition and a more rapid one. So gradual transition, this would be an example of somebody who's on 150 of methadone, and let's say they were quite stable on 150. They were quite stable, but they wanted to rotate off of it because they were having issues with side effects or QT issues, or they just wanted to try something else. So this is somebody who's quite stable like this, and who's not using illicitly on top of that, and is quite reliable in their clinic appointments, and not missing any doses. This would be an example of how you might choose to rotate that person. So 150 of methadone. We're using a 1 to 6 ratio here, on the slightly conservative side. Maybe they're older, maybe they're not using illicitly on top of that. We're feeling comfortable using a slightly more conservative range. So 150 of methadone would calculate it to about 900 morphine milligram equivalents, or 900 of Canadian. And we're not going to make that switch all at once. We're going to make it gradually. So on day 1, they're on 150 of methadone. Day 2, we'll reduce their methadone dose by 100 milligrams and add 600 milligrams of Canadian to that. Now, you could do this in different ways. You could reduce it by 50 milligrams of methadone and add 300 and draw it out slightly more. There's no clear roadmap here. But the idea is that we're reducing the methadone, we're stepping down the methadone and adding the slow release oral morphine in a sort of a gradual transition. When you're doing this off of methadone, recognizing that methadone takes many days to achieve a steady state after a change in dose, both up and down, we may drop their methadone from 150 to 50 and add the 600 milligrams of Canadian, and we'll leave them there for a week. So from days 2 to 8. On day 9, we can drop the remaining 50 milligrams of methadone, add 300 more milligrams of morphine, and then day 10 plus will be on 900 milligrams of morphine, and we can continue to titrate by about 100 milligrams every 24 to 48 hours as needed to achieve that therapeutic dose. So this would be, again, an option that I might consider in somebody who I had a relationship with, who I knew was coming back consistently over the weeks, wasn't missing doses, didn't have other significant comorbidities, and wasn't using on top, was on quite a stable dose. Method two would be a more rapid transition. So this is somebody who maybe you have a need to get them off of methadone much quicker because of some contraindication or some concern. Maybe they're just very unstable in the methadone and it's not serving them well, or maybe there's not the opportunity to be quite so slow and deliberate in the transition, and because of travel purposes or time purposes or just their individual preference, they want to make this switch happen quicker. So in this case, we can make the rotation all at once. This individual here we're talking about will be on 100 milligrams of methadone, and we're deciding that we want to switch them over quite quickly. Let's say because they're still quite unstable on 100 milligrams. So if they're on 100 milligrams and still using on top of that quite heavily, we may want to use a slightly more generous ratio. Let's use 1:8 for the purposes of this case. So that would calculate out to 800 morphine equivalents. So we would quite simply stop methadone on day one or after day one and switch them to that 800 milligrams of slow-release oral morphine. And then again, continue to titrate that as per our guidelines every 24 to 48 hours up to a therapeutic dose. If you're doing this rapid transition in somebody who's not using on top of it, who you want to be a bit more careful with, whether using a 1:8 or a 1:6 rotation, there may be other, depending on the situation, you may also want to include a further dose decrease to account for a phenomenon called incomplete cross tolerance. This might be something that I would consider if somebody was on, let's say, 200 milligrams of methadone, and I just didn't feel comfortable switching them immediately to that high of a dose of Cadian. So you may include a 20 to 30% dose decrease to account for incomplete cross tolerance, and then continue to titrate the Cadian by 100 milligrams every 24 to 48 hours as needed. So that would be a more rapid transition. This, truthfully, is what I tend to do more in my practice, but I work in a unique setting where I'm either in hospital and I have resources around me that let me navigate this a little bit more easily, or I work with in the rapid access addiction clinic at St. Paul's, which is we may have a more transient population, and we may need to just make changes quickly in order to ensure that we keep people engaged. Moving on then, and we can circle back to this in the question period, but moving on and talking about transition from buprenorphine naloxone to slow-release oral morphine, I noticed in the pre-session poll, this was something that people felt less comfortable with. It's actually quite easy. In that there's not really any magic to it, even though it often will require a fair amount of slow-release oral morphine titration. Really, there's no easy way to calculate a morphine milligram equivalence from buprenorphine naloxone and just rotate them over to a higher dose of SROM, given that it is a partial agonist and given that it does have that ceiling for respiratory depression. So I would not suggest trying to. There's conversion tables on Butrans patches, but I would not suggest trying to use those conversion tables for Suboxone and transition them over to higher doses of a full agonist. Rather, we simply suggest stopping the buprenorphine naloxone and administering the first dose of slow-release or morphine 24 hours after the last buprenorphine naloxone dose. There will still be some Suboxone in their system at that point, given that it's got about a 30-hour half-life, but it'll wash out fairly quickly. You can update as per regular slow-release or morphine induction protocols. To be clear, it will not cause slow release or precipitated withdrawal. That is a phenomenon that will only happen when you're switching from a full agonist to buprenorphine, not the other way around. So you can transition away without fear of precipitated withdrawal, and you can reassure your patients that won't be a challenge. So for instance, somebody who's on 24 of bup and is just not doing well on this, they're not finding it effective for them, I would just stop on day one and start them on a starting dose of slow-release oral morphine on day 2 and titrate as per protocol. One of the more common questions, again, that I get on lines like 24/7 is, what about Sublocade? What about somebody who's not on Suboxone but actually on Sublocade? And I put this figure up here again, not to focus on any details, but just as a helpful example to recall that when somebody's on Sublocade, they're going to have buprenorphine in their system for quite some time after last injection. So in panel A here, you can see somebody who's achieved steady state on a 100 milligram dose. Panel B shows a steady state on a 300 milligram dose. And you can see that it's minimum 8 to 12 weeks, even on 100 milligrams, before they're dropping down into a subtherapeutic range. And it's probably detectable for 6 months or so after after their last dose. For somebody who's on 300 milligrams, they're not dropping down into that subtherapeutic range until 5 months or more from their last injection. 2 nanograms per ml, I'll say, is an somewhat arbitrarily defined therapeutic dose of buprenorphine. So they're going to be in not just detectable, but physiologically relevant doses of buprenorphine for 5 or 6 months after discontinuation. So it's not something that you can easily factor into your decision making. Truthfully, I would start them on Cadian or SROM as I would normally and titrate up as I normally would, just in the back of my mind, remembering that there is another variable here that is changing over time. And I would just check in about that and consider whether any SROM adjustments may need to be made weeks or even months out, depending on what's actually happening with the bupe. So in summary, slow-release oral morphine is a full agonist oral OAT option with a growing evidence base. It is one of the 3 approved formulations of oral OAT we have in our province. Indications for slow-release oral morphine may include ongoing withdrawal and craving, intolerable side effects, or contraindications to other OAT medications, or just simply patient preference. And transition are periods of higher risk. They should be approached thoughtfully and collaboratively with each patient, and often do require a bit more checking in, but should not be scary. And if they do serve a patient's long-term goals well, then absolutely, we do these all the time. They're generally well tolerated and just part of providing patient-centered care. These are our references, and with that, I think